We are ready to begin, so I'll let you open and then we'll move on.
Very good. So I had a gavel, you'd hear a gavel. I'm gaveling the meeting of January 27th, 2021 of the ACIP to order. We will begin at this time. Thank you all for coming and attending this emergency meeting. I suspect this will be the first of several this year. We have new members, which I will introduce and welcome in a little bit. But now I'll turn it back over to Dr. Cohen for welcoming comments.
Great. Thank you, Dr. Romero. Good morning, everybody, and welcome to this January 27th emergency ACIP meeting. So this meeting will be live webcast, and no registration was required for this meeting. The topic of today's meeting, all of the subjects will be related to COVID-19 vaccines. Next slide. Apologies, everyone. I'm having to do the slides. So slides presented at today's meeting are available on the ACIP website. The live webcast videos will be posted on the ACIP website after the meeting, and meeting minutes are also posted on the ACIP website within 90 to 120 days of the meeting. We are also posting short summaries of these emergency meetings within a week of completion of the meeting. We ask that all members, liaisons, and ex officios who are on the Zoom call to mute your lines at all times until you're called on for discussion. When Dr. Romero opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Romero will take questions from the first from the voting ACIP members, and then from ex officio and liaison representatives. So if you're not a voting member and you've raised your hand, please be patient and we will get to you. We will try to stay on schedule per the meeting agenda. We do have a time set aside this afternoon for public comment, and we will make every effort to have that public comment happen at the time that we have on the agenda. And we ask that ACIP members please disable their video for this discussion. There are no votes occurring at today's meeting. I'm going to hand it over to Dr. Romero, who is going to introduce our incoming ACIP members, who we are very excited to introduce to you today.
Thank you. Thank you, Dr. Cohen. So welcome, and I'll begin by introducing the four new members. And we'll start with Dr. Wilbur Chen, who is Professor of Medicine at the University of Maryland School of Medicine. He's also the director of the University of Maryland Baltimore Travel Medicine Practice. His research interest is in developing vaccines against pathogens which afflict low and middle income countries. He's the co-investigator of the NIAID funded Vaccine Treatment and Evaluation Unit and the NIAID funded Collaborative Influenza Vaccine Innovation Centers. Welcome, Dr. Chen. Next is Dr. Matthew Daly. He's a senior investigator from the Institute of Health Research at Kaiser Permanente in Colorado. He has extensive experience in the areas of vaccine safety, parental vaccine hesitancy, and immunization services delivery. He's an investigator in the Vaccine Safety Data Link, and he's an associate professor in the Department of Pediatrics at the University of Colorado School of Medicine. Next. Next is Dr. Camille Cotton. She's the director of the Transplant and Immunocompromised Host Infectious Disease Division at Massachusetts General Hospital. She's an associate professor at the Harvard School of Medicine. Please mute your mics. She's an infectious disease clinician with special expertise in the area of the care of complex patients undergoing solid organ transplantation with cancer. She's a national expert in vaccination and zoonotic infectious diseases in the immunocompromised host. Next slide, please. Our next member is Dr. Sarah Long, who really needs no introduction. She's well known in pediatrics. She's a professor of pediatric infectious diseases at Drexel University College of Medicine. She's an attending physician in infectious diseases at St. Christopher's Hospital for Children. She has over 4 decades of contributions in the field of pediatric infectious diseases, especially in the areas of the FDA. She's been a member of the FDA's Vaccine and Related Biological Products Advisory Committee and the AAP's Committee on Infectious Diseases, the COID. Next slide, please. Last on our list, although she's not a new member, this is Dr. Grace Lee. She will be serving an additional term from July 2020 to June of 2021. This is a bridging period so that she will become our next chair of the ACIP. So welcome all, and we look forward to working with you all in the coming months, and it's years for those of you that remain after I depart. So Dr. Cohen, should I proceed to take roll?
Yes, Dr. Romero, that would be great.
Great, thank you very much. Okay, so I'm going to start with the ACIP members. When I call your name, please state your affiliation and if you have any conflicts at this time. So I'll begin. I'm Jose Romero. I am the Arkansas Secretary of Health. I'm also a professor of pediatrics and infectious diseases at the University of Arkansas for Medical Sciences. And I have no conflicts. Dr. Kevin Alt.
My name is Kevin Alt, and pardon me, I'm a professor of obstetrics gynecology at the University of Kansas, and I have no conflicts.
Thank you. Good morning and welcome. Ms. Lynn Bata.
Good morning, Lynn Bata here. I am a public health nurse functioning as the clinical consultant for the Minnesota Department of Health, and I have no conflicts.
Thank you. Welcome. Dr. Bell.
Jeff Bell, clinical professor, Department of Global Health, University of Washington. No conflicts.
Good morning and welcome. Dr. Bernstein.
Good morning. I'm Hank Bernstein. I'm a professor of pediatrics at the Zucker School of Medicine at Hofstra Northwell. I have no conflicts.
Good morning, welcome. Dr. Chen.
Wilbur Chen, Professor of Medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. And I have no conflicts for this morning's discussion.
Welcome, thank you. Dr. Fry.
Sharon Fry, Professor of Internal Medicine at St. Louis University, Division of Infectious Diseases. I have no conflicts. Thank you.
Good morning and welcome. Dr. Cotton.
Good morning, Camille Cotton from Massachusetts General Hospital. I have no conflicts.
Dr. Lee.
Good morning, Grace Lee, Associate Chief Medical Officer at Stanford Children's Health, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts.
Good morning, welcome. Dr. Long.
Sarah Long, Professor of Pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict.
Welcome and good morning. Ms. McNally.
Good morning, Veronica McNally, President of the Franny Strong Foundation, located in Michigan, and I have no conflicts.
Good morning and welcome. Dr. Paling.
Good morning, Kathy Paling, Professor of Pediatrics at Lake Forest School of Medicine, no conflict.
Welcome and good morning. Dr. Sanchez.
Morning, I'm Pablo Sanchez. I'm a professor of pediatrics at the The Ohio State University Nationwide Children's and Neonatologist and Pediatric Infectious Disease Specialist, and I have no conflicts. Thank you.
Welcome, thank you. Dr. Talbot.
This is Kip Talbot from Vanderbilt University Medical Center. I'm a associate professor in infectious diseases and medicine, and I have no conflicts.
Thank you all. So all the members of the ACIP voting block are present. I will now go on to take the role for ex officio representatives, and I will start with the Centers for Disease Control and Prevention with Dr. Messonnier.
Dr. Romero, Dr. Messonnier is not here at this moment, but she will be joining us in a few minutes.
Very good, thank you. Centers for Medicare and Medicaid Services, Ms. Hance.
Good morning, this is Mary Beth Hance for CMS.
Good morning, welcome. From the Food and Drug Administration, Dr. Doran Fink.
Hi, Doran Fink, FDA, Office of Vaccines.
Good morning, welcome. From Health Resources and Services Administration, Dr. Rubin.
Good morning, this is Mary Rubin, Division of Injury Compensation Programs, HRSA.
Thank you, welcome. Dr. Weiser from the Indian Health Service.
Good morning, Captain Tom Weiser from Indian Health Service.
National Institutes of Health, Dr. Bajal.
Yeah, good morning. John Weigel from the National Institute of Health of National Institute of Allergy and Infectious Disease.
Thank you and welcome. Office of Infectious Diseases and HIV/AIDS Policy, Dr. Beckham.
Good morning. This is David Kim representing the Office of Infectious Disease and HIV/AIDS Policy in the Office of Assistant Secretary for Health.
Thank you, Dr. Kim. Welcome. I'll now move on to the liaison representatives. Starting with the American Academy of Family Physicians, Dr. Rockwell.
Pamela Rockwell, present, no conflicts.
Welcome, good morning. American Academy of Pediatrics, Dr. Maldonado.
Bonnie Maldonado, good morning, everybody. Bonnie Maldonado, Professor of Global Health and Infectious Diseases, Chair, Committee on Infectious Diseases for the American Academy of Pediatrics.
Welcome. American Academy of Pediatrics, AAP Red Book, Dr. David Kimberlin.
David Kimberlin, University of Alabama at Birmingham, and editor of the AAP Red Book, present.
American Academy of Physician Assistants, Dr. Leger.
Good morning, Marie-Michelle Leger, American Academy of PAs, Director of Clinical Education.
Good morning and welcome. American College Health Association, Dr. Chai.
Dr. Romero, this is Sharon McMullen from the American College Health Association from Cornell University, and I'm signing in for my colleague, Dr. Tavi Chai, UNC Chapel Hill, and myself.
Thank you very much. Welcome. American College of Nurse Midwives, Dr. Hayes, Carol Hayes.
Present.
Thank you. American College of Obstetricians and Gynecologists, Dr. O'Neill Eckert.
This is Dr. Linda Eckert, and I am present. Thank you.
Thank you. Welcome. American College of Physicians, Dr. Goldman.
Thank you, Dr. Jason Goldman, affiliate professor at Florida Atlantic University, General Internal Medicine. Pleasure to be here. Thank you.
Welcome and good morning. Dr. Schmader, American Geriatric Society.
Ken Schmader here for AGS.
Good morning. Dr. Gluckman for America's Health Insurance Plans.
Yes, Bob Gluckman, Chief Medical Officer, Providence Health Plans, present.
Good morning and welcome. Dr. Coyle, American Immunization Registry Association.
Dr. Coyle is present.
Thank you. Good morning. American Medical Association, Dr. Freihofer.
I'm Dr. Sandra Freihofer, General Internist in Atlanta and Adjunct Associate Professor of Medicine at Emory, Liaison for the American Medical Association.
Good morning and welcome. American Nurses Association, Dr. Riddle.
Chad Riddle here. Good morning.
Good morning. Welcome. American Osteopathic Association, Dr. Grog.
Yeah, present and just got my second COVID shot minutes ago.
Congratulations and welcome. American Pharmacists Association, Dr. Foster.
Good morning, everybody. This is Steve Foster.
Association of Immunization Managers, Dr. Howell.
Molly Howell, AIM, also the North Dakota Immunization Director.
Good morning and welcome. Dr. McKinney for the Association for Prevention, Teaching, and Research.
It's Dr. Paul McKinney, Professor of School of Public Health and Information Sciences, University of Louisville.
Thank you. Association of State and Territorial Health Officers, Dr. Shaw. We'll come back around. Dr. Arthur for the Biotechnology Innovation Organization.
Good morning. Phyllis Arthur for Bio, present.
Thank you. Good morning. Council of State and Territorial Epidemiologists, Dr. Hahn.
This is Dr. Led, and I am representing them this morning, and I am present.
Thank you very much, Dr. Led. The Canadian National Advisory Committee on Immunization, Dr. Quash.
Yes, I'm here, NACI Chair. Good morning.
Good morning. Infectious Diseases Society of America, Dr. Baker.
Good morning. This is Jeff Duchin, Professor of Medicine at the University of Washington, Division of Infectious Diseases and Health Officer for Public Health, Seattle and King County, representing the Infectious Diseases Society of America and also covering for National Association of County and City Health Officials today.
Thank you very much. Welcome. International Society for Travel Medicine, Dr. Barnett.
Elizabeth Barnett, representing the International Society for Travel.
Good morning. National Association of sorry, Dr. Duchin, that's you again, sorry. National Association of Pediatric Nurse Practitioners, Dr. Stinchfield.
Nurse practitioner Patsy Stinchfield, representing NAPNAP. Good morning.
Good morning. Thank you. National Foundation for Infectious Diseases, Dr. Schaffner.
Good morning. This is Dr. Bill Schaffner for the NFID. Present.
Thank you. National Medical Association, Dr. Whitley Williams.
Good morning. This is Sonia Hutchins. I'm representing Dr. Pat Whitley Williams today for the National Medical Association.
Thank you very much. Welcome. Pediatric Infectious Diseases Society, Dr. O'Leary.
Sean O'Leary, University of Colorado, present.
Good morning. Pharmaceutical Research and Manufacturers of America, Dr. Robertson.
Good morning. Corey Robertson for Pharma, present.
Good morning. Society for Adolescent Health and Medicine, Dr. Middleman.
Hi, it's Amy Middleman from SAM. Good morning to everyone.
Welcome. Good morning. Society for Healthcare Epidemiology of America, Dr. Dries.
This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care, present.
Thank you for being here. And then let me go back up to see if Dr. Shaw from the Association of State and Territorial Health Officers. Okay. Thank you all for being here. Dr. Cohen, I'll turn it back over to you. If you have any comments.
No, I think we skipped over two of the slides inadvertently, and I apologize to everyone for my spastic slide starting a few minutes ago. But the two slides that we skipped over, we're just going to pull up quickly. Mostly just want to focus on the public comment and to remind everybody that if they wish to submit a written public comment during the meeting, you can go to the ACIP website and there will be a link, and this is to regulations.gov, and the docket number is listed on this slide. We do have an oral public comment period. We had people sign up for oral public comment when that closed 2 days ago, and we did have more people who asked to make an oral public comment than we had time, so we did randomly selected the individuals who will be speaking today. Next slide. And finally, you heard from the ACIP members related to their conflicts of interest. There are no votes occurring at today's meeting, and there is discussion is not related to making recommendations for a product-specific issue, so conflicts of interest. So for the purposes of this meeting, all of the ACIP members do not have to recuse themselves from any parts of this meeting today. And I believe, Dr. Romero, that is it, and we can go ahead and jump into the agenda.
Thank you very much. So we'll begin. First topic of the day is coronavirus disease 2019 vaccines. We'll have an introduction by the work group chair, Dr. Beth Bell. Dr. Bell, please.
Thank you, Dr. Romero, and good morning to everyone. Could I have the next slide, please? First, I just wanted to draw the attention to our participants and listeners to 3 publications that appeared in December. The ACIP's interim recommendations for the use of the Pfizer-BioNTech vaccine, interim recommendations for the use of the Moderna vaccine, and updated interim recommendations for allocation of COVID-19 vaccines, which was published at the very end of December. And the URLs are at the bottom of this slide for those who are interested. Next. In January, the COVID-19 work group covered a number of different topics, looking both at current situation and looking forward. The topics we covered included a number of safety updates, COVID-19 in children, plans for clinical studies of COVID vaccines in children, plans for vaccine effectiveness studies, and a number of issues related to clinical guidance for the use of mRNA COVID-19 vaccines. Next, please. Today's agenda includes, it's kind of divided into 4 parts. The first is an update on the AstraZeneca COVID-19 vaccine development program by Dr. Tanya Viafana. And then Dr. Cohn will update us on COVID-19 vaccine administration. We'll then have a series of presentations about vaccine safety monitoring. First, an introduction to the vaccine safety technical subgroup, which goes with the acronym VAST. The COVID-19 vaccine safety update by Dr. Tom Shirubakuro. And finally, the VAST assessment of the safety data to date, again by Dr. Grace Lee. After another break, we'll hear 2 presentations related to children. First, COVID-19 epidemiology among children, Dr. Angela Campbell, and then pediatric COVID-19 clinical trials by Dr. Emily Erbelding of the NIH. Finally, they'll hear a summary of plans related to COVID-19 vaccine effectiveness studies and the work group interpretation of what we've been working on in January and next steps by Dr. Sarah Oliver. Next, please. And here again are the work group members, including the ACIP members, ex officio government members, liaisons, consultants, and our 2 CDC co-leads. All of the participation of all of these people is extremely appreciated and valued. Next, please. And the large list of CDC participants who assist us in so many different ways. Next, please. And thank you very much. We can go on to the next presentation.
Thank you, Dr. Bell. So next, we will have Dr. Tanya Viafana present from AstraZeneca on the AstraZeneca COVID-19 vaccine AZD1222. Please, Dr. Viafana.
Thank you and good morning. On behalf of AstraZeneca, I'd like to thank the ACIP for the opportunity to present on our COVID-19 vaccine, AZD1222. In addition to the AstraZeneca team that's online this morning, we are joined by Dr. Andy Pollard, the Professor of Pediatric Infectious Disease at Oxford, Children's Hospital and director of the Oxford Vaccine Group at the University of Oxford. And he is the chief investigator on our trials that were conducted under the sponsorship of Oxford University. Next slide, please. These are our forward-looking statements. Next slide. This morning, I will cover a background on the AZD1222 adenoviral vector platform and the early clinical data that supported moving forward into our US phase 3 study. We will also cover the non-IND phase 3 efficacy and safety trials, for which we have recently had an interim analysis that was published in the Lancet, and for which the UK MHRA issued a temporary supply authorization. We will also cover vaccine storage and handling later on in the presentation. Next slide, please. Our phase 3 trial in the US is ongoing and the enrollment is complete. The trial will be the primary basis for the emergency use authorization application to the FDA, with supporting data from the non-IND trials conducted outside the United States. AstraZeneca in April 2020 committed to a partnership with Oxford University to ensure broad and equitable vaccine access globally and not for profit during the pandemic. Efficacy, safety, and immunogenicity of our vaccine were just demonstrated in 4 ongoing trials conducted in the UK, Brazil, and South Africa. And as I mentioned previously, data from these trials supported authorization for temporary supply by the UK MHRA, and we also have emergency use authorization in several markets. The vaccine is supplied in 5 ml preservative-free, non-latex multi-dose vials to be stored at 2 to 8 degrees Celsius for at least 6 months. Next slide, please. I'll now cover background on the platform, as well as early clinical data that supported moving forward to phase 3. Next slide, please. So the AZD1222 vaccine is the non-replicating chimp adenovirus vector vaccine expressing the spike SARS-CoV-2 antigen. The chimp adenovirus vector avoids issues with pre-existing immunity that's commonly seen with human adenoviruses. The platform has been shown to induce strong B and T cell responses after a single vaccination. Prior to April 2020, the group at Oxford had conducted several phase 1 studies and early stage studies with this vector platform used for a variety of disease pathogens, and about 330 subjects had been vaccinated with various vaccines using the platform. This data was really instrumental to leverage moving forward very quickly into clinical studies with the AZD1222 vaccine. The dose that was selected for clinical development moving forward is 5 × 10 to the 10th viral particles as an intramuscular injection given in half an ml. Next slide, please. In collaboration with Oxford, we have conducted a global clinical development program to support our goal of equitable access. The first trial that was started in April 2020 began in the UK, and it was a phase 1/2 study, and I'll speak more about that. The interim results from that study supported moving forward into phase 2/3 studies in the UK, a phase 3 study in Brazil, and a phase 1/2 study in South Africa. It was also instrumental in moving forward into the US phase 3 study, which also includes enrollment in sites in Chile and Peru, and I'll talk about that later on in the presentation. As you can see on the slide, we have a number of studies ongoing globally, mostly safety and immunogenicity studies to support licensure and use in those locations. Next slide, please. COV001 was the first in-human study and a phase 1/2 study that enrolled in the United Kingdom. It enrolled 1,077 participants, 18 to 55 years old. The study was originally designed to evaluate a single dose of the vaccine candidate, but we also had initially included a cohort of 10 participants who received 2 doses of the vaccine 28 days apart. Participants were randomized to receive either a dose of the vaccine or a control vaccine for meningitis. This slide illustrates antibody responses on the left of the slide and neutralizing antibody responses on the right in response to administration of either a single dose or 2 doses of the AZD1222 vaccine. As you can see on the left in the hand of the slide, after a single dose of vaccine, there's a nice rise in antibody titer in response to vaccination. When given a second dose 28 days later, there's a boost of these antibody responses. For both a single dose as well as 2 doses of vaccine, responses are similar in range to what is seen with convalescent serantibody titers. On the right-hand side of the slide is an assay that was run by Public Health England looking at neutralizing activity against the SARS-CoV-2 virus. And here you can see that after a single dose of the vaccine, approximately 91% of vaccinees have a neutralizing antibody response, and after 2 doses, 100% of vaccinees have a response. These data were very supportive in moving forward with a 2-dose vaccine strategy, which we implemented for the rest of the clinical development program. Next slide, please. Older adults are disproportionately impacted by COVID-19 with severe outcomes. They are a priority population for vaccination and inclusion in clinical trials. Prior to being able to enroll older adults in our large-scale efficacy studies, we included them in a phase 2 portion of the COV002 trial, which is a phase 2/3 study. This slide illustrates neutralizing antibody responses in older adults when compared to younger adults. And specifically, you'll see at the bottom of the legend there, the younger adults are the 18 to 55 years old group receiving 2 doses of vaccine in the crimson color. And then the older adult populations are in that turquoise color and then dark blue color on the slide. What you can see on this slide, and again, here we look at neutralizing antibody activity, is that the older adults have similar immune responses in terms of neutralizing antibody activity to the younger adults 18 to 55 years old. This data was supportive in allowing us to move forward to enroll older adult populations in our phase 3 program. Next slide, please. A key question for COVID-19 vaccine development has been whether or not vaccines cause antibody-dependent enhancement. Preclinical animal studies demonstrated no evidence of ADE for our vaccine. We also know that Th2 polarization is associated with ADE from previous SARS-CoV-1 vaccines and other vaccines that have been studied. This slide shows results from intracellular cytokine staining to determine the cytokine profile of CD4 T cells in vaccinated individuals. Participants vaccinated with AZD1222 demonstrated a Th1 biased T cell response with induction of interferon gamma, IL-2, and TNF cytokines. Notably, Th2 cytokines were not detected, and these are all spike-specific responses. This data was also supportive of us moving forward into our phase 3 study. Next slide, please. AZD1222 was well tolerated in phase 1/2 studies. Most adverse events were mild to moderate in severity, and the majority resolved within 7 days. Local and systemic reactions were 20% less frequent after the second dose, and adverse events were similar in nature to those previously reported for the viral vector platform. And they included injection site pain, feeling feverish, muscle ache, and headache. Local and systemic reactions were more common in participants given AZD1222 than the control vaccine. And we observed less reactogenicity, both local and systemic, in older adults. In older adults above the age of 70, about 30% had fewer mild to moderate local reactions than those less than 55 years. And a similar trend was seen for systemic reactions when comparing those over 70 to those less than 55. So in totality, the antibody responses we observed, the Th1 biased cytokine profile, and our safety data were supportive in moving forward to our phase 3 study in the US. We also have other data that's been published in the Lancet and Nature that profiles the immunology and immune responses in the vaccinees in more detail. Next slide, please. I will now cover our US phase 3 trial. The phase 3 trial in the United States was designed to evaluate safety and efficacy of the vaccine in over 30,000 volunteers. The study began in August of 2020. Volunteers were randomized 2-to-1 to receive either 2 doses of our vaccine or saline placebo control. The study is ongoing in 88 sites in the US, Chile, and Peru. We included adults 18 years and older with a target to include 25% of subjects above the age of 65. We also agreed enrollment of diversity targets with the US government. It was really important to us to have a very diverse population represented in our phase 3 study. Next slide, please. The case definition for our primary endpoint is indicated on this slide. Our primary efficacy endpoint is the first case of PCR positive illness occurring more than 14 days post-administration of the study intervention. On the table on the slide, you can see more detail in terms of our case definition, how we define the clinical criteria for a case. In category A, we include lower respiratory tract involvement, one or more of the criteria seen here. And then in category B, systemic or other symptoms that reflect COVID-19 disease. The safety endpoint is incidence of adverse events for 28 days post each dose. And we also look at adverse events, medically attended adverse events, and adverse events of special interest from day 1 post-treatment throughout the study. Next slide, please. Here I will share where we reached and landed with our diversity targets for enrollment, as well as older adults. You can see on the left-hand side of this slide in that table, and this is just focusing on US enrollment. It doesn't include the Peruvian and Chilean sites. But within the US, we enrolled 11.2% in the Hispanic Latinx population, about 9.8% in the Black or African American population. And you can see the other race and ethnic groups highlighted on the slide. For older adults, we came very close to our target of enrolling 25% above the age of 65 with about 23.6%. The majority of our participants had a comorbidity. And just to highlight a few of the main comorbidities we see, including obesity, diabetes, asthma, chronic kidney disease, coronary artery disease, among others. We enrolled 32,459 participants. And the reason we went above the 30,000 was really to try to optimize our targets in diverse populations. 26,327 received their second dose by January 21st. Next slide, please. I will now address our clinical hold, since several people on the working group asked us to address this. We did have a clinical hold during the course of the study. Again, the study was initiated on the 28th of August. And AstraZeneca paused the study on the 6th of September in response to an event of transverse myelitis that was reported in the phase 2/3 study conducted by the University of Oxford in the UK. This was done out of an abundance of caution for the safety of participants in this study. During the clinical hold, we provided a lot of information to the FDA, including additional details on neurological events in studies sponsored by AstraZeneca and Oxford, as well as any analyses of available clinical safety data for the vaccine, as well as other ChAdOx vector platform vaccines that were requested by the agency. We implemented a number of changes in study conduct in response to the event. We updated the risk language in the informed consent form and the investigative brochure, and we made a number of protocol changes, including accelerated and increasing safety reporting. We also established an independent expert neurology panel. I should emphasize that both for the US study and the studies conducted ex-US that were sponsored by Oxford, there are DSMBs that review the safety information in these studies on an ongoing basis. The participant who experienced the event continues to recover, and we continue to provide the FDA and all of the agencies with information requested around safety events that occur in the studies. Next slide, please. I'll now cover the non-IND phase 2/3 program interim results for the ex-US studies that were sponsored by Oxford. And this is from a data cut of November 4th. Next slide, please. So the interim analysis was a pooled analysis across 4 ongoing studies, as I've mentioned previously. The analysis included data from 23,745 participants across these studies. We've already talked about the UK COV-001 study. COV-002 is the ongoing phase 2/3 study that included adults 18 years and above. COV-003 is a phase 3 study conducted in Brazil that includes adults 18 years and older. And COV-005 is a phase 1/2 study that's being conducted in South Africa, including adults 18 to 65 years. The primary endpoint of the study, again, nucleic acid amplification test positive symptomatic COVID-19. Prior to conducting any analysis, a global statistical plan for pooling data across the studies was developed and discussed with regulators, and pre-specified analyses that would contribute to the assessment of efficacy were agreed and discussed. On the right-hand side of the slide here in the bottom, in crimson, you see the population that was included for our primary efficacy analysis, which included participants from the UK and Brazil phase 3 studies, which are the 2 studies that met the inclusion criteria for this interim analysis, with 5 cases, at least, of COVID-19. On the right-hand side of the slide, at the bottom right here, are the number of participants included in the safety analysis across all 4 studies, and that includes everyone in all 4 studies that was enrolled. And you can see here the median days for follow-up post-dose 1 is 105 days, and post-dose 2, 62 days for the safety population. Next slide, please. This slide highlights the results from the phase 3 pooled interim efficacy analysis for AZD 1222. The pooled analysis demonstrated a 70.4% vaccine efficacy at preventing symptomatic COVID-19. We also looked at the subgroups that were included in this pooled analysis, since some of the participants in the UK received a low dose and a standard dose of the vaccine, the standard dose being the 5 times 10 to the 10 viral particles, which are being studied in the US study. The subgroup analysis for participants receiving 2 doses of the 5 times 10 to the 10 viral particles demonstrated efficacy at preventing symptomatic COVID-19 of 62.1%. There were no hospitalizations or severe COVID-19 in vaccinated participants from 21 days after the first dose. Next slide, please. Across the 4 studies, the vaccine exhibited a favorable safety profile. We had SAEs occurring in 168 participants across the 4 studies, 79 of whom received AZD 1222 and 89 of whom received the control vaccine or saline control. In those 168 participants, there were 175 SAEs, of which 4 were considered possibly related to the intervention, either the experimental vaccine or the control. In the AZD 1222 group, the 2 SAEs are noted here. One was a case of pyrexia, the other was a case of transverse myelitis, which we discussed. And in the control group, there was a case of autoimmune hemolytic anemia, as well as a case of transverse myelitis. In terms of solicited adverse events, the majority usually resolved within a few days of vaccination. The reactogenicity profile was similar to what I described before for the phase 1/2 study that was conducted in the UK. And generally, again, milder and reported less frequency of solicited adverse events after the second dose in the older adult population, as we previously discussed. Next slide, please. I'll now cover vaccine storage and handling. So the vaccine can be stored in the refrigerator 2 to 8. It has a shelf life of 6 months, and it cannot be frozen. In terms of administration, the vaccine will be provided as a multi-dose vial. After the first puncture, it can be stored up to 6 hours at room temperature or up to 48 hours at 2 to 8 degrees Celsius, with a total storage time not to exceed 48 hours. No dilution or reconstitution of the vaccine is needed. Next slide, please. So in summary, next slide. We believe that AZD1222 offers a potential to address the global COVID-19 crisis. We showed you that it induces robust immune responses against SARS-CoV-2 spike protein. We showed the ELISA antibody responses as well as neutralizing antibody responses and a strong Th1 bias CD4 T cell responses. And as I mentioned before, there is a lot of immunology data that's been published already on the vaccine. The US phase 3 study is ongoing with 32,459 participants who were enrolled across diverse backgrounds with comorbidities and also including older adults. We have demonstrated efficacy and safety of the vaccine in 4 ongoing trials conducted in the UK, Brazil, and South Africa. And AZD1222 has been authorized in 18 countries as of January 25th. Next slide, please. I'd just like to acknowledge everyone who's worked on this program and who continue to work 24/7 to contribute to the solution for this pandemic, and most of all to our trial participants. Thank you.
Thank you very much, Dr. Villafana, for that very clear and information that you presented us. So this is open for questions. If you'll please raise your hand. Let me begin by asking a two-part question. Firstly, the immune response, the antibody response elicited by the vaccine, have you looked at its effect on the variants that have now arisen? And second of all, do you have any idea what the prevalence of the mutants, variants that were reported in the literature, that are reported in the literature from South Africa and Brazil were at the time of the study? Thank you.
Thank you for that. I'll start and then turn it over to Andy Pollard for the, and I understand the question is focusing on the ex-US conducted studies that Oxford ran. We're continuing, we're continuing actually working to understand the activity of our vaccine against variants that are circulating in the places that we're conducting the studies. Andy, would you like to add to that in terms of the frequency of what we've seen so far?
Yes, thanks very much, Tanya, and hello to everyone from Oxford. So at this moment, we have an analysis underway for the UK variant, which is B117, which is both looking at neutralizing antibody data, which we hope will be completed within a few days and submitted for publication to make that available to everyone. But also, since the middle of December, that variant has been dominant in the UK because it spread so rapidly. And so we should be able to put together an analysis on efficacy against that probably by next week. And that is very much related to the ability to get sequence data, which we can sequence most of the other swabs that we get back. So that's the sort of timescale is within a week or two to have some data on the UK variant. In parallel, we're also looking at neutralizing activity against the South African variant, and there is certainly a possibility there in the trial to be able to look directly at efficacy against the South African variant. Again, it's really taken off in the country since November, and about 90% of the disease is thought to be caused by the new variant. So if we can pull all the sequence data together, for that also is possible that we can address that question, and both on efficacy and neutralizing activity. The trial sites in Brazil are not directly around the epicenter for the origin of the Brazil variant, and so I don't at this moment know whether we'll be able to make direct comment about efficacy in Brazil. But we are working with the local teams on sequencing the virus from those individuals in the trial who have symptoms, and also looking at neutralizing antibody against the virus. And that's just taking, will take a little bit longer because we're just slightly behind on the sequencing there.
Thank you very much for those answers. Let me see Dr. Paling, please.
Hi, Dr. Villatana. Thank you very much for a clear and informative presentation. I wanted to ask a question about the Th1, Th2 response. And we know that is really important. Could you clarify what the sample size was? Is this human, non-human primate? What data, where did this data come from? A little bit more details would be helpful. Thank you.
Dr. Paling, could you get closer to the mic, please?
Yes.
Oh, yes.
Sorry, sorry, I didn't hear the question. I was just going to say, but I don't know if Beth Kelly are.
Okay, I'm sorry.
Did you hear the question?
Yes.
I believe I sure did hear the question. So yeah, I'm happy to walk you through the data that we presented on Th1 and Th2 responses, which was 70 participants, all from the UK studies, so COVO1 and COVO2. And that was approximately 40 subjects between the ages of 18 and 64, and 30 subjects greater than the age of 65. So in that analysis, we looked at lineage markers, so CD3, CD4, CD8, functional markers, so the Th2 cytokines, the Th1 cytokines were interferon gamma, IL-2, and TNF alpha, as Tanya mentioned, and the Th2 cytokines were IL-4 and IL-13. And we looked at additional phenotypic markers of CD69, CD28, CCR7, and CD45RA. And I think what the data you saw was that we got strong induction of Th1 cytokines in those study participants after a first dose of AZD1222. Those cytokines did not rise but stayed elevated after a second dose. And we did not see induction of Th2, so spike-specific Th2 cytokines in CD69 activated T cells, CD4 T cells.
Thank you.
Thank you. Dr. Fry, please.
Thank you. Thanks for a great presentation and also the explanation about the transverse myelitis. I have two just very quick questions that I'm just looking for clarification. You mentioned that there were 4 SAEs that were thought to be related, and I didn't catch what they were, and I was wondering if you could tell us. And my other question is, how many actual cases were there in the placebo group versus the vaccine group for which you came up with an efficacy of 60%? I missed that. Thanks.
Thanks. Maybe we can go back. Is it possible to go back to the slide with the SAEs? And I will also ask Sam Lindgren, who's our head of patient safety, to address this. Sam?
Yes, I think we need to scroll forward to the Oxford study.
Yeah.
So that was the one. Thank you. Perfect. So regarding the SAEs that were considered possibly related, this is what Tanya referred to earlier. So in the ACID 1222 group, there was one SAE of pyrexia that occurred shortly after the vaccination. It resolved quickly after paracetamol. It was one report of transverse myelitis that occurred after the second dose. That was mentioned earlier in the presentation by Tanya. And in the control group, there was one SAE of autoimmune hemolytic anemia shortly after vaccination with the control vaccine. And also in this control group, there was one case of transverse myelitis occurring after the first vaccination of the control.
Thank you very much.
Thank you. Sorry, the second question was around the cases in the vaccine versus control group for the vaccine efficacy. I believe that was the question. And we do have a backup slide that has the VE in more detail. So if we can go to that, if that's helpful, or.
Please go ahead.
Yeah, if you can go to the backups, sorry, and if you can move to the next, I believe it's the next slide. Yes. So here you can see the numbers in the control versus the vaccinated group.
Thank you.
Thanks.
Jose, I think you might be on mute.
I am not hearing anything. Yes, go ahead. Sorry, forgive me. Thank you, Dr. Talbot.
Good morning, and thank you for presenting all of this data. My question is more about the number of trial participants who have dropped out as they've become eligible for vaccine in the U.S. and how that might impact your data collection and the duration of follow-up. Thank you.
Thanks, Kip. I would like to ask Antonio Gonzalez-Lopez to respond to that. Antonio?
Yes, this is a really good question because about 3,000 participants has already decided to abandon the study because they are susceptible to receive one of the available vaccine now in the US. This number is not, obviously this is random. We cannot determine which group they are allocated, but the potential impact on the efficacy is going to be very limited because the efficacy is driven by the number of cases, and we are very, very close to have the number of cases for the interim analysis and also for the primary analysis. So we cannot expect a major impact on the evaluation of efficacy. But the reality is that if this number of subjects continue to increase in the future, we will have probably some how to evaluate what is going to be the impact in the safety follow-up, especially in the long-term safety follow-up. And we are working in preparing a potential plan of doing crossover in all participants to establish the safety follow-up system to guarantee that we can keep in the study as much participants as possible, especially for safety. But as I say, we don't expect a high impact on the evaluation of efficacy.
Thank you.
Thank you. Dr. Quash.
Yes, thank you for your presentation. Just a question. Could you specify if there's a difference between the AstraZeneca vaccine and the one that is produced by the Serum Institute of India, which seems to have the same platform?
It's the same vaccine construct.
So are you considering—
They're just manufacturing it in India.
Okay, but is it, so are you calling it an AstraZeneca product when it comes out of the?
No. So we have a sub-license with Serum Institute of India for them to manufacture for India and also for lower middle income countries. So they're manufacturing the vaccine and it's called Covishield.
Okay, and do you have any lot-to-lot comparisons of immunogenicity or anything?
They conducted a study in India that included 1,600 participants, and within that study, Covishield was included as well as AZD 1222.
Thank you very much.
Dr. Long, please.
Yes, Sarah Long. Thank you for the presentation, and it's wonderful to hear Dr. Pollard's voice, who's been an esteemed colleague and researcher over decades in the UK. I have a question. Would you maybe show us the neutralizing antibody response by age that you showed us? And my question, it's two parts. Maybe they're connected, maybe they're not. It seemed as if in the middle age group, there was either no or a very modest booster response from dose number 2. I wonder if you have any thoughts about that. And also, I noted in your Lancet publication that there was amendment to the protocol for the prophylactic use of paracetamol in some of the sites. I wonder if, and we noticed that reactogenicity was less on the second dose. I wonder if those were related. And I also wonder if you looked at antibody responses in those who received paracetamol and those who did not. And as we know, prophylactically, acetaminophen in the United States has been associated with diminished response, whether or not clinically significant, but diminished response to, for instance, pneumococcal conjugate vaccine. Thank you.
Thanks very much. I'll start and then maybe hand it over to Beth to answer as well as Andy. But prophylactic use of paracetamol did not have any impact of immunogenicity in our studies. So that just to start there. And Andy, you can comment on whether this group, the older adult population, 55 to 69, received prophylactic paracetamol.
No, they didn't receive paracetamol. I mean, we've seen consistently with a second dose of this viral vector that reactogenicity is lower, and it seems to just be a feature of that the reactogenicity is more with the first dose. And so we did have a subgroup where we tried the prophylactic paracetamol and saw that there was some impact, particularly on the more severe systemic reactogenicity with some paracetamol. But it's a modest effect, and in fact, most people find the reactogenicity tolerable anyway. So the subsequent studies have not had prophylactic use of paracetamol. It is just reactive in those who have symptoms.
Thank you, Dr. Lee.
Thank you so much. First, I wanted to just thank you for investigating the variants and how it might impact vaccine efficacy. I think we're very much looking forward to understanding that data, and appreciate your team working on that, given the location of where your trial sites are. The second question, a comment I have, or question, is really around, while I recognize this is a different platform from our mRNA vaccines, I'm wondering if you could comment on whether there were any severe allergic reactions, comments about Bell's palsy, and whether or not you observed any pregnancies during the trial, and if so, is there a registry, or are you following those pregnancies along? Thank you.
Thanks for the question. Sam, would you like to take that one?
Tonya, it's Andy here. Perhaps I'll take that.
Go ahead, Andy. Go ahead.
So on the pregnancies, of course, in a population as large as this in the current trials, which is about 23,000, a lot of younger adults who are healthcare workers, there are a large number of pregnancies, and they're being followed through to afterbirth of the child. So we're obviously because of the relatively short duration, we don't have the data yet, but we are making good progress on that. And just on your comment on the variants, you're absolutely right. It's a challenge in very widely distributed in different countries to obtain all the sequence data. So as I said, we're hoping to get the sequence data, but it may be still some time before we can get the final results pulled together.
And Sam here, if I may, sorry, I pushed the wrong button. So the question was about Bell's palsy, and in the Oxford studies, there were 3 Bell's palsy reported in the ACIP 1222 group, and there were 3 Bell's palsy reported in the control group. And just to add on what Andy already said on the pregnancy, yes, we certainly plan for in our pharmacovigilance plan post-marketing for a quite huge pregnancy register. Thank you.
Thank you. And could you please comment, sorry, on the severe allergic reactions and whether you observed any in the trial?
Sorry, yeah, I missed that part. We have had very little hypersensitivity reported in the clinical trials, and we did not have in the clinical trial any report of anaphylaxis that could be seen as associated with a vaccine. But as with any vaccine, I think with a broader exposure, I think we will need to be, and we are very surveillant and will have that as active surveillance regarding hypersensitivity reaction occurring post-authorization.
Perhaps just to add to that, from the ingredients that are in the vaccine, the only one that might be associated with anaphylaxis would be polysorbate 80, which hasn't really, it's a very widely used product and isn't particularly associated with anaphylaxis, to my knowledge. And it is also one of the ingredients, for example, in the adjuvanted flu vaccine, which doesn't have any excess rate of anaphylaxis associated with it.
Thank you all. Dr. Kimberline.
David Kimberlin, AAP Red Book. 2 questions. On slide 15, you showed the racial and ethnic demographics for the U.S. Enrollees. And then underneath that, it said there were roughly 32,500 participants enrolled. Are you saying that those 32,500 were the U.S. participants enrolled, or is that the global, including Peru and Chile? And if the latter, how many are in the U.S.? That's my first question.
Thanks. I'll start and get clarification from Antonio. The 32,459 is the total population that we enrolled in the study, and I believe it's about 3,600 that were out of Peru and Chile.
Correct. You're right.
All right, excellent. And my second question is, are there pre-existing chimp adenovirus antibodies in different populations on different continents? Africa, for instance, does the baseline population have antibody to the chimp adenovirus, or do y'all know that yet?
Well, I think there have been historic studies done with a population from the Gambia, if I remember correctly, where there was low pre-existing immunity to the chimp adeno. Beth, perhaps you can comment on that, but in general, in populations in the northern hemisphere and in many of our sites, we don't see pre-existing immunity.
That's correct. So in non-African populations, I believe the seroprevalence is well under 10%.
And I guess I'm thinking about the global aspects for this particular product. How about in Africa? Do you know what the baseline rates are there?
Andy, can you speak to the study in Gambia by chance?
Yeah, I mean, I think I don't have in my head the actual seroprevalence, but it is low in all populations, but there is some variability. The key question, I guess, is whether that impacts on responses to spike protein. And we haven't seen any significant differences in responses in different countries in the immune response to spike protein. And indeed, if you look at responses to the second dose, there isn't a correlation between the anti-vector neutralizing antibody that's induced and the response to spike protein with the second dose. So far, at least with that measure of immunity, we haven't seen any relationship that suggests that that's a problem.
Excellent, thank you.
Dr. Bell.
Thank you. I'm wondering if you've been able to do any subgroup analyses that you could share with us, either stratified by age or by comorbidities or by racial ethnic composition.
So I think in the backup slides, if we could go to the slide that has the single dose efficacy and comorbidity, that's included in the deck. Next slide, next slide. No, next slide. So here is from the Oxford studies, the efficacy in the comorbid population. You can see at the bottom of the slide there of about 73.4%. And yeah.
Go ahead.
No, I was going to say, in terms of the older adult population, for the first interim analysis, we didn't have a large number of older adults in that analysis, so the confidence intervals are wide, but with subsequent analyses, we will have more older adults and we'll be reporting out on efficacy in that older adult population. Andy, is there anything you want to add on that?
No, I don't think there's anything to add on this at the moment.
Thank you, Dr. Maldonado.
Oh, sorry. Yeah, can you hear me? Yeah, so thank you very much. I have two questions. The first one relates to the chimp adenovirus vector. And we obviously know that these adenovirus platforms, regardless of serotype, can trigger innate immune responses. And so I imagine that you've already investigated some of those baseline innate responses. But what about the potential for development of subsequent immunity, specific adaptive immunity to the adenovirus platform, and the likelihood that that could impact booster responses over time, even though this is a chimp adenovirus vector? So that's my first question.
Perhaps I can just respond to this. This is Andy Pollard again. So the data that we have so far, as I mentioned in the previous answer, is that we don't see a relationship between anti-vector immunity and the spike protein responses to the second dose. So that provides some reassurance. But you're right, of course, that we need to know about people if they were having a future booster dose after they'd already had two. So in the UK trial, we do have a subgroup, there's a small subgroup, but a subgroup who previously were in trials of the same viral vector, and they've been brought back and have received two doses of the coronavirus vaccine with the viral vector. So we will be able to answer that question very soon.
Thank you. And I don't know if you addressed this question before, and maybe I missed it. Sorry, but I'm curious about what you think might be the biological plausibility of the or explanation for the differential responses and efficacy between the two regimens, given that one is a low dose standard versus standard. Have you discussed that, and maybe I missed it?
We didn't discuss it in the context of this presentation, but if we can go to the slide, there's a slide in the backup that shows immune responses for both groups. Keep going. Next slide. So here, what we've done some more assessment of the data, And within this study, participants received 2 doses, but at varying intervals, depending on where they were located and enrolled in the study. And what we're showing here, highlighted in the red box, actually is that if you look at participants who received 2 of the standard doses or the low dose standard dose combination and account for interval, the responses look very much the same. So in fact, we think that interval is actually what is probably associated with the increased efficacy that we're seeing for that low dose standard dose group, just because many of those participants were in the longer interval group.
Thank you.
Thank you.
Thank you. Our final question will be from Dr. Eckhart, and then we will proceed to a break.
Thank you very much. I was just wondering, you mentioned that you had several people in your pregnancy registry. Can you give us a better idea of what that number is? Thank you.
So the pregnancy registry is being set up. So based on the approval or authorization in the UK, and as being discussed with also other authorities. So the pregnancy registry is not yet up and running, but we have a commitment to have that set up as quickly as possible to enroll subjects.
I think just a follow-up question, maybe I think I didn't ask clearly enough. I just wondered how many pregnant women you ended up having in your trials. Thank you.
So with the data set analyzed before Christmas, there were, I would say, 21 women that were reported that had pregnancies. So that was the totality.
Thank you very much.
And just to be clear, these are individuals who became pregnant after vaccination. These aren't individuals who were pregnant at the time of vaccination.
Correct, based on the exclusion criteria, absolutely.
Thank you all for those answers to the questions. We will take a 15-minute break and come back at 38 minutes after the hour. Thank you.